Hola, muy buenas tardes. Yo soy el doctor Luis Montiel, soy cirujano HPB y es un placer para mí participar en el octavo Congreso de la Asociación Mexicana de Hepatopancreatobiliar. Le doy un afectuoso agradecimiento y saludo al doctor Javier Melchor, presidente de nuestra asociación, a todos los participantes y el comité científico por su amable atención. Es para mí un honor participar en este módulo de debate sobre resecciones en metástasis hepáticas. ¿Existen límites? La primera ponencia será dada por el doctor Michael De Angelica. Se encuentra en el Hospital Memorial Sloan Kettering Cancer Center. Él es director del programa del Fellowship en Cirugía HPB y Cirugía Oncológica. El tema que nos dará será cirugía compleja en hígado. Y posteriormente el doctor Federico Aucejo, que está de la Cleveland Clinic, y él es el director del programa de cáncer de hígado y cirugía oncológica, nos dará el tema de infusión arterial hepática y trasplante hepático. It's a pleasure for us. Thank you for your attention.
Okay, I'm going to be discussing complex hepatic resection and our experience with hepatic artery chemotherapy for metastatic colorectal cancer of the liver, and really try to give case against transplantation for this disease. The reason we're debating this is that the experience from Norway has really brought forth the role of transplantation for this disease. But Norway is a different world where they're being attacked by so many liver grafts, they don't really even know what to do with it anymore. So when it comes to transplantation, Norway is a different kind of place. They have an opt-out system. They have a low rate of liver disease, and they have too many liver grafts with wait times of less than a month. This, of course, is not the case in the rest of the world, but it did result in experimentation for metastatic colorectal cancer. And the question we have to ask, has it resulted in progress, or really was it a mistake? So whenever debating, it's important to frame the question clearly. We're talking about liver-confined metastases. The primary tumor has been resected. There's usually some element of treatment or a test of time. We're generally talking about young and healthy patients, not older patients who are more common with this disease. We really want to discuss whether transplantation will play a prominent role going forward. It's important to realize that whenever you're proposing a technical solution to the complex biology of cancer, you are generally the underdog, as nicely illustrated in this slide. Of course, some people may not remember, but transplantation was done for metastatic colorectal cancer in the past, and it was a dismal failure. 5-year survival was very poor and less than 20% in almost all series. Graft loss was bad and complications were high. Of course, I can hear the transplant surgeons saying, but their high rate of graft loss is not the way it is today, and things are going to be better today. So let's look at the data out of Norway, the modern data. And as I'll point out many times, a lot of these data are the result of extreme selection. And their first trial, called SECA-1, really actually had such restrictive inclusion criteria that had to widen that throughout a year because they could not recruit very well. But in general, patients had to have a good performance status, had to be on chemotherapy for a minimum of 6 weeks, and have no extrahepatic disease. And over 5 years, only 21 patients were transplanted. If you consider that the population of Norway is about 5 million, and I estimated that there are about 2,500 or 3,000 cases of colorectal cancer a year, this is an extremely tiny percentage of the problem. This really illustrates just the extreme selection that goes on when we look at these patients. So one look at that and you realize this is extreme selection. When you look at the median time from the resection of the primary tumor, it was 3 years to transplant for patients with metachronous disease and 16 months for those with synchronous disease. But you have to consider the outcomes for systemic chemotherapy. Response rates are about 50%. The median time to progression is 8 to 10 months, and response to second-line chemotherapy is very poor, generally under 20%. So the patients in the SECA-1 trial are 2 to 3 years into therapy with no obvious progression and are well enough for transplantation. This is a really important concept. A lot of people assume that these heavily pretreated patients who have been followed for a long time have a poor prognosis. But heavily pretreated does not always mean poor prognosis. In fact, those that thrive and long enough to be heavily pretreated are those with the best biology and the best prognosis. So here are the outcomes for SECA-1. At a median follow-up of 27 months, the 1-year recurrence-free survival was 35%. 2/3 of the patients had recurred within 1 year. And at the time of their last follow-up, 19 of 21 recurred, and I can tell you essentially all of them will recur. The median time to recurrence was 6 months after the transplantation. So the argument is made that despite the rapid and frequent recurrence, the predicted 5-year overall survival was 60%, and that should justify transplantation. But remember, these are patients who were selected for this because they survived a long time of therapy and had indolent disease. Overall survival can be a measure of biology and selection, especially when you're living with chronic malignancy. Recurrence-free survival, which in this trial was abysmal, nearly everybody had recurred within 1 year, really is a better measure of the impact of treatment most of the time. So let's take a look in detail at comparative treatment, which for the most part would be systemic chemotherapy. Now, this is a trial of FOLFIRI versus FOLFIRI. And these are much worse patients. These are older patients. These are patients with diffuse metastatic disease not confined to the liver, and at the very beginning where there is no selection. The median follow-up for this trial was 16 months, and 5-year overall survival for the FOLFIRI arm was 15%. And if you take out patients who then went on to resection, which would be an unfair thing because those patients should be part of this, it's 10%. So in the Norwegian trials, they also tried to compare to chemotherapy patients. And they compared to the Nordic 7 trial, which were unresectable, BRAF wild-type, liver-only disease, and less than 66-year-old patients. That was the comparison they made. You can see that the recurrence-free survival is exactly the same, but the overall survival looks much better. Again, this can be the result of selection and indolent biology. Additionally, 27% of the patients went on to resection, and those were excluded. So can you imagine if those patients were included, this would look a lot similar, those two curves. So a really important point here is how selection works. When you alter the denominator with selection, you can easily increase your percentage. Just consider 10% 5-year survival. If the 105-year survivals are of 1,000 patients, you're at 10%. But with selection, the patients who survive longer, the patients who do better, the patients who respond to chemotherapy, the patients who are younger and healthier, as you cut down your denominator, you can easily increase your percentage. So when you look at 5-year overall survival, you have to always consider the denominator. And it's the denominator that's as important, if not more important, than the actual survivors themselves. So the chemotherapy arm, you could easily change from 10% to say 40 or even higher percent if you change the denominator. So then we move on to the SECA-2 trial, which really tried to push selection even further. They added some more selection criteria. Patients had to have normal blood tests, no weight loss, a low BMI, at least first-line treatment with at least 10% response, and at least 1 year from their initial diagnosis and listing date. Also, of course, any reason why the investigator wanted to have a patient not participate would count. Now, again, an extremely uncommon operation. 15 patients were accrued over 5 years, 3 a year. And the median time from diagnosis to transplantation was 24 months. Consider what I've just told you. This is the same story, but even more selection. The denominator will get smaller and the percentage overall survival gets higher. And the outcomes of the second trial are really very similar. At a median follow-up of 36 months, you have encouraging overall survival. However, there were only 2 disease-free 3-year survivors and 1 disease-free 4-year survivors. They are all likely to recur of their disease. So again, the point I'm making is that transplantation in these trials is an exercise in extreme selection. Young, healthy patients with indolent disease who survive and remain healthy enough to receive a liver transplant. It's for a radical alteration of the denominator, pushing percentages higher. And remember, even with chemotherapy, there are long-term survivors, and if you're highly selective in that group, you can push the percentages higher as well. Everybody recurs. And remember that overall survival is often more of a reflection of indolent biology rather than the impact of treatment. Now, I am not a transplant surgeon, but when I spent some time to read about the morbidity of liver transplantation, I realized it is a morbid operation and a significant price to pay. It seems that the overall perioperative morbidity is about 70%, and any complications don't even get resolved within 1 year. So a quarter of biliary strictures, a third of hernias, 10% of infections linger for longer than a year. And beyond that, there is rejection with lifelong immunosuppression, intensive long-term medical follow-up, and the time and money required for that. It's a complex operation with a huge price to pay. And furthermore, graft loss is a serious issue over time. You can see in the green line, the 1-year graft failure rate is about 10%. And as you go up to 3 years, it's about 20%. And it goes up and up. And that means that either patients are dying or they have to go a repeat of their transplantation. So the issue is this. This kind of morbidity is justified in a patient dying of liver failure, but are they justified in chronic cancer patients that all are going to recur? typically you gotta get a response, but these are not typical transplant patients and outcomes will be better. No, that's correct, but they're all chronic cancer patients who nearly all recur, requiring ongoing chronic anti-cancer treatment, which makes it perhaps even more complicated. And even a brief look at the SECA-1 and SECA-2 trials reveals that these are morbid operations. As a non-transplant surgeon, I was kind of shocked at this. SECA-1 had an 80% complication rate, 33% major complication rate, 2 retransplantations, 5 reoperations for bleeding, 4 arterial complications. And I do love that they developed, 8 patients developed hernias, which they bled on chemotherapy. I find that kind of funny. In the SECA-2, not a lot of detail was given, but about a 50% major complication rate, which in my mind is very, very high. So often the argument about overall survival is made that these patients recur and then they can be re-resected. And a lot of detail has been published about this. In SECA-1, remember, at least at the time of recording, 19 of 21 had recurred, the majority involving the lung. There were many re-resections, and after re-resection, 7 were NED, but they'd only had a median follow-up of 11 months since their last procedure. Really, these patients are still likely not to be NED. In SECA-2, remember, a very short recurrence-free survival. 6 of 8 recurrences involved the lung, many re-resections, and again, 11 were free of disease but had very limited follow-up. Everybody's free of disease after operation. It takes time to recover. So we have actually studied the salvage rate and the cure rate after salvage resections in patients who have undergone prior resections, not transplantations. And it turns out that only 5% of recurrences after re-resection are cured. So 95% of salvage operations are still followed by recurrence. You need long-term follow-up to document being truly NED, especially in patients with indolent disease. You likely, in the SECA trials, have not cured any of these patients, and they will continue to recur. And again, remember that overall survival often reflects the natural history and not necessarily the impact of the transplantation. Of course, the other problem is where are all the livers going to come from? Well, usually the answer is they're going to come from live donors. But the question is, are we really going to ask young, healthy people to donate livers for a non-curative transplant metastatic cancer? There is no price to pay for donating a portion of your liver. In the Korean donor experience, out of 10,000 donors, there were 53 deaths, and this was 3-fold higher compared to a matched normal population. Interestingly, the causes of death were cancer and car accident, but a very high rate of suicide. That's quite concerning. There's obviously a psychological price to pay for this. In the A2all experience, out of 740, there were 740 patients, there were 98 infections, 49 hernias, 42 psychological difficulties, 20 unplanned re-explorations, 21 with ascites, etc., etc., etc. There's also a price to pay when you donate your liver. So let's move on to what can be done besides transplantation. This is a study that we did where we gave hepatic artery chemotherapy and tried to resect patients after response. The primary endpoint was complete resection. It was a prospective phase 2 trial with pump and systemic chemotherapy, and these patients had very advanced unresectable disease. Nearly all of them had synchronous disease. 2/3 of them had had prior chemotherapy. The median number of tumors was 13, and nearly all of them had a high clinical risk score. With a response rate of 73%, we were able to convert about half of the patients to complete resection. And here are the outcomes here. And I'll get to the actual cure rates in a second. But at a median follow-up of 81 months, if you look at the green line in this graph, the mean overall survival was 8 months, the 5-year overall survival was 36%, and the median progression-free survival was 13 months. Like the transplant series, there were many salvage operations, many of which remained NED, and I'll go through these in detail. So if you compare those who got resected to those who didn't with a landmark analysis, you can see the long-term survival is at least 60 to 70%. And we looked in great detail at those that we may have cured. We found that 9 of 64 patients in this trial were actually free of disease. 1 had a complete response to pump chemotherapy and has been free of disease for over 100 months. 5 remained ND after resection, with all of them with a follow-up of over 5 years. And we did do post-resection salvage resections, and we know 3 of those patients are alive, all of them with 5-year follow-up. So we believe we actually cured 1 in 7 of these patients with chemotherapy and resection. Now, resection is not straightforward resection. This is where we get to complex hepatic surgery. And I don't have time to go into great detail, but to do these kinds of operations, to attack lobar complex disease, you need to know how to do parenchymal sparing resections. I believe you need to be facile with intraoperative ablation, and you should also be able to perform 2-stage resection. So when you consider parenchymal sparing surgery, the major issue, of course, is the margin. If you're only going to take out small bits of liver and preserve major parts, you're going to be close to tumors. This is data from our center, but it's been documented in other centers that negative margins, even if they're as small as less than a millimeter, but still have better outcome, positive margin. And even with positive margins, they're long-term disease-free survivors. Furthermore, a positive margin doesn't always mean you've left cancer behind. In fact, a small minority of patients with an R1 margin will have a local recurrence, and therefore the great majority of the time, despite a histologic margin, all of that cancer has been removed. And the local recurrence rates are actually quite similar to those with negative margins. Even more interesting, when you're going to be close to a tumor, we're not very good at predicting who will actually have a positive margin. When we looked at those patients who had less than 1 millimeter margins, now, in these patients, you knew you were close to tumor. We looked at every factor we possibly could, and we could not find one that was associated with a positive margin. And therefore, if you're going to be close to a tumor, you can't really predict which ones are going to be histologic positive. And now there's a growing literature on R1 resections, especially R1 resections along major blood vessels. And this is a critical thing when you're trying to preserve parenchyma and blood vessels to drain and feed that bit of liver that you're leaving behind. And now there's a growing volume of literature that shows that outcomes in these situations with R1 margins, especially on vascular structures, can have very good long-term outcomes without local problems with the tumor. So with this in mind, you can perform parenchymal preserving surgery, be close to a tumor, and realize that the margin is not predictable and probably doesn't matter too much in terms of your technical ability to take out the tumors. When I was a medical student, we only really considered a right lobe and a left lobe, and for decades, that was only the operation done. You took out the right side or the left side. And believe it or not, I think this is done more frequently, even in modern surgery, than most people realize. The reality is that you have to consider the segmental nature of the liver and be able to perform any segmental, subsegmental resection of preserved parenchyma. And in those situations, you can resect complex bilobar disease. So parenchymal sparing surgery accomplishes a number of things. First of all, less extensive resections, it's much safer, and you can do this in patients with limited disease. And it allows bilobar resections when you take out a segment or a wedge resection of the liver, such that you can then either take out the whole other side or other small portions of the rest of the liver. In general, we see less blood loss and lower incidence of positive margins. We studied this years ago when we were starting to get away from lobar resections. And in bilobar disease, as you can see, over from the early 90s to the early 2000s, we were treating patients mostly with extensive tumors and more extensive over time. Yet the rate of lobar resections went down, the rate of number of resections went up, 90-day mortality went down, and survival and hepatic disease-free survival remained relatively unchanged over time. And in fact, over time, I think this has changed even more over the next 20 years, with lobar resections being even less common. So this is just one example of how parenchymal preserved surgery can be done. This is a patient with an inferior right hepatic vein, where we resected segments 7 and 8, taking the main right hepatic vein, preserving the accessory right hepatic vein, and taking a small wedge resection that you can see of segment 6, leaving the majority of segment 5 and 6 intact. Now this, in a patient with bilobar disease, allows you to tackle the other side of the liver. Without these kinds of techniques, you cannot do complex bilobar surgery. I also think being facile at ablation is critical. A small, deep contralateral tumor in the right location can be treated very effectively with intraoperative ablation. This was our initial experience, and we had a local control in nearly 90% of all patients early on in our experience with intraoperative ablation. And if you look at a more modern comparison of microwave and radiofrequency ablation with small tumors in the right location next to major vessels, you can see you get over 90% local control with microwave ablation. So the use of intraoperative ultrasound and good ablation techniques, this can be an extremely helpful technique to tackle bilobar disease. This is an example of where these techniques can be useful. The right-sided tumor requires a right hepatectomy. And whether you do this in 1 or 2 stages, the left-sided tumors with the use of ablation and wedge resections can easily be tackled. 2-stage hepatectomy is often necessary to clear bilobar disease and was described nearly 20 years ago at this point. This was our initial publication a few years ago, 2-stage hepatectomy, where 90% of patients completed a 2-stage resection with a high number of tumors, a significant morbidity but no mortality, and a 5-year survival of 50%, and salvage rates that were quite high. So again, bilobar disease can be tackled in 2 stages as well. So to try to summarize my talk, the results of transplant may be a reflection of extreme selection and explained by indolent biology rather than the impact of the treatment. Transplant for colorectal liver metastases is in general a non-curative operation. Transplantation carries significant major morbidity in both the short and long term, and graft availability and allocation limits general applicability throughout the world. I also hopefully have shown you that with the use of specific resectional techniques and effective chemotherapy, similar outcomes can be obtained without the morbidity and difficulty of transplantation. Thank you very much.
Liver transplantation and transarterial chemoinfusion pump HAI for the treatment of advanced liver metastases from colorectal cancer. Federico Osejo, director of the Cleveland Clinic Liver Transplantation Program. Liver transplantation for hepatic metastases of colorectal cancer that are non-resectable was attempted at first in the decade of the 90s. However, due to the inadequate selection of patients and technical complications related to the transplantation, the results were suboptimal, and as a consequence, the practice was abandoned. However, recently, based on a pilot study from the Oslo University, we observed that it's possible to get a survival of 5 years between 50 and 60% in selected patients, which is significantly superior to the survival of patients with unresectable metastases who are only candidates for systemic therapy. Analyzing the pilot study SICA-1 of the University of Oslo based on 21 patients, we observed that 80% of the patients presented metastasis synchronous, 76% presented progression on chemotherapy. The median of the VON clinical risk score was 3, and as expected, patients presented an extensive and heterogeneous presence of number and size of lesions. When analyzing the inclusion criteria of the SICA-1 study, we can highlight the resection of the primary tumor, the adequate functional capacity of the patient, a minimum 6 weeks of systemic therapy, the absence of extrahepatic metastasis, the absence of tumoral mutation BRAF, and a median time between the resection of the primary tumor and the liver transplantation for synchronous metastases of 36 months and for metachronous metastases of 16 months. With a follow-up with a median of 27 months, the survival results of the SICA-1 study showed overall survival at 1, 3, and 5 years of 95, 68, and 60% respectively, which is significantly superior than the survival observed in patients who are only candidates for systemic therapy because of non-resectable liver disease. Regarding tumor-free survival, it was 35% after 1 year and 0% after 3 years from transplantation, thus observing a high rate of tumoral recurrence post-transplantation. In the SICA-1 study, we can see factors that favor survival, and they include carcinoembryonic antigen less than 80, maximum tumor diameter less than 5.5 centimeters, time from resection of the primary tumor until 2 years of the transplantation, tumoral response pre-transplantation to systemic therapy, and in line with this, we observed that those patients with a greater combination of negative factors had a lower survival rate than those patients with fewer negative factors. When we analyze the survival at 10 years of the patient group in the SICA-1 study regarding the Oslo criteria, we observed that there were no survivors at 10 years among those patients with more than 2 negative factors, which highlights the relevance of an adequate patient selection. It was also observed that among the prognostic factors, the location of the primary tumor corresponding to the right colon was associated with a worse chance of survival. After the SICA-1 study, the same group from the University of Oslo published the results of SICA-2, including 15 patients with a follow-up of a median of 36 months. A modest response rate was observed to systemic therapy. The time from the resection of the primary tumor to transplantation was more than 1 year. The overall survival at 1, 3, and 5 years was 183 and 83% respectively. The tumor-free survival at 1 year, 2, and 3 years was 53, 44, and 35% respectively, and the FUNC score from 1 to 2 at the time of diagnosis was associated with a better prognosis. This highlights an improvement in the elements of patient selection that corresponded to better results when compared to the results of the previous SICA-1 study. When we analyze the criteria of inclusion of the SICA-2 study and we compare them to the SICA-1 study, we observe that the point of greatest difference lies in the systemic therapy pre-transplantation response, because it was observed that 76% of the patients presented tumor progression pre-transplantation in the SICA-1. However, the patients with tumoral progression pre-transplantation were not included in the SICA-2 study, highlighting the importance of this prognosis factor that was reflected in the superior results observed in the SICA-2 study. When analyzing some of the most relevant differences between the SICA-1 study patients regarding the SICA-2 study patients, we found a lower degree of FUNC score and Oslo score in the SICA-2 study as compared to the SICA-1, lower levels of carcinoembryonic antigen in the patients of the SICA-2 study compared to the SICA-1, and a lesser degree of liver tumor mass and less tumor metabolic activity defined by PET scan in the SICA-2 study, and all of this reflects an improvement in the tumoral biology selection of the patients in the SICA-2 study regarding the SICA-1 study patients that corresponded to the better results observed in the SICA-2 study. This slide shows another small European retrospective study including 12 patients, of which 10 received a prior resection. 11 out of the 12 got systemic therapy with good tumor response. And when we observed the time between the resection of the primary tumor and the transplantation, it was a median of 41 months and a range of 12 to 97 months. So it was considerably longer, thus highlighting again the importance of the role of time as a revealing element of the tumor biology. And the median of carcinoembryonic antigen levels was 16.6, with a range of 2 to 314, showing levels that are relatively not as high. The results of this small European retrospective study show that it's possible to observe, when analyzing survival, levels of survival that are similar to those observed in other indications for liver transplantation. And now I would like to share with you the experience to date in our institution in the Cleveland Clinic regarding our inclusion criteria that were modeled based on those of the University of Oslo, with the addition of the implementation of living donor transplantation for those patients without portal hypertension or minimum or moderate portal hypertension, in which case the use of a live donor was favored with the use of the left lobe, and cadaveric transplantation for patients with a MELT score that was high with portal hypertension as well, and minimal residual tumor volume in response to the aggressive combination of pre-transplantation therapies, including systemic therapies and locoregional therapies such as radioembolization, ablation, stereotactic radiation, and the implementation of chemotherapy by transarterial infusion pump HI. Now I will describe the 7 cases that were assessed and approved for liver transplantation due to advanced liver metastases that are non-resectable in the Cleveland Clinic. The first case is a 45-year-old woman with sigmoid cancer with liver metastases that are non-resectable, as you can see in the presentation tomography. After the resection of the primary tumor, the patient received systemic treatment with good tumor response. And as you can see in the scans, however, the PET scan pre-transplantation shows residual tumor presence that is metastatic and active, and then the patient receives a live donor liver transplantation using the left lobe. We observed a total of 2 adverse factors according to the Oslo criteria in this case, and the explantation showed multiple foci of viable tumor. 6 months after transplantation, the patient shows a multifocal relapse of the tumor affecting the lungs and the abdominal lymph nodes, as you can see in the scans, and as a consequence, the patient receives systemic therapy, and unfortunately dies due to complications of tumoral progression almost 2 years, more exactly 23 months after transplantation. In this second case, this 44-year-old female patient with a diagnosis of right colon cancer and advanced synchronic metastasis. As you can see in the slides, the patient was initially undergoing systemic therapy, neoadjuvant systemic therapy with very good tumor response, as you can see, and receives a semicolectomy, right semicolectomy with multiple resections in the left lobe, in which afterwards the patient receives an embolization of the right portal vein as a preparation for a right hepatectomy and a preparation for the transarterial infusion pump. Here you can see the scans showing the post-liver resection, the wedge resection in the right lobe, and the implantation of the transarterial pump. Now, as a result of the therapies, and as a result of the chemo infusion transarterial therapy through pump, we see a biliary toxicity that is significant and that leads the patient to show multiple episodes of cholestasis and cholangitis requiring multiple hospitalizations up to the point where the patient is prepared and approved for liver transplantation. The patient receives the liver transplantation from a living donor using the left lobe, and in the histopathological analysis of the explanted liver, we see that there is no residual tumor evidence. Today is almost 2.5 years, a little more than that, from the date of the transplantation of this patient, and the patient is fine with no radiological evidence of a tumor relapse. In this third case, a 43-year-old male patient shows up with a sigmoid colon cancer with synchronous advanced metastasis, as you can see in the slide. After receiving systemic therapy, the patient is subject to a sigmoidectomy, followed by systemic therapy with a combination of the resection, ablation, and pump infusion. And then the patient receives a combination of systemic therapies and radiation therapy for residual tumor control. As a consequence, as can be seen in the tomography, the patient developed hepatotoxicity produced by the multiple therapies received, and consequently the patient develops cirrhosis with associated complications of cirrhosis and portal hypertension that can be seen, for instance, as ascites, peritoneal varicose veins, and so on, as you can see in the images. The patient, as a consequence, is assessed, approved, and listed for transplantation with a residual liver tumor load that is mild to moderate, as we can see in the PET scan pre-transplantation. With a MET score that is high, the patient receives a cadaveric donor transplant, and the histopathology of the explanted liver shows 4 foci of residual metastases that are small. 16 months after transplantation, we see a single metastatic pulmonary focus, and as a result, the patient receives the injury resection and systemic therapy. At 2 years and 6 months after the transplantation, today, the patient is well with no evidence of tumoral relapse. This fourth case is a complex case of a young woman diagnosed with ascending colon cancer with advanced synchronous metastasis, diagnosed in 2014. The patient received systemic therapy followed by colectomy and transarterial infusion pump placement, and subsequently receives a combination of therapies including liver resection, external radiation ablation, and again ablation, causing damage to the central bile duct. Beginning here, the patient requires treatment with percutaneous bile stents and develops complications related to portal hypertension, including bleeding esophageal varicose veins and repeated episodes of cholangitis requiring multiple hospitalizations for intravenous antibiotic treatment, etc. Due to an increase in the carcinoembryonic antigen levels, at this level, the patient continues systemic treatment with immunotherapy. And in December 2018, 4 years after the initial diagnosis, the patient is assessed and approved for liver transplantation at our facilities in Cleveland Clinic. Due to the technical difficulties that were anticipated in this case, the patient was not offered live donor transplantation, and due to the small size of the patient, in spite of the high MELD score, she had to remain in the waiting list for a year or so until a cadaveric donor was available. The patient received the liver transplantation with cadaveric donor, and unfortunately, after the reperfusion of the organ, she died during the operation due to complication of intravascular coagulation complications, disseminated pulmonary thromboembolism, and right heart thrombosis. And strikingly, the histopathology of the explanted liver showed absence of residual tumor activity, showing the effectiveness of the multiple aggressive therapies received pre-transplantation by the patient. In this fifth case, a 50-year-old woman diagnosed with rectal cancer and synchronous liver metastasis has a resection of the primary tumor followed by systemic therapy. After a year, she receives the right hepatectomy and then wedge resections, ablation, and external radiation for the treatment of liver metastasis, and this is followed by a combination of systemic therapies, and she's referred for transplantation assessment due to the presence of residual tumoral presence in the liver and moderate manifestations of splenomegaly and thrombocytopenia. Subsequently, the patient receives the radioembolization to treat the residual liver lesions and continues with systemic therapy until the time of the transplantation. The pre-transplantation PET scan shows moderate residual tumoral activity, as you can see on the screen, and the liver donor transplantation is programmed. Unfortunately, the procedure was aborted intraoperatively because a diaphragmatic tumoral invasion was evident that matches the lesion that you can see in the PET scan. In this sixth case, a 57-year-old man with the diagnosis of sigmoid cancer and synchronized liver metastasis is assessed, and the patient receives systemic therapy and sigmoidectomy in 2017 with 4 interventions of radioembolization for the local control of the liver metastasis. The patient shows very good tumoral response to the local regional therapy and continues with systemic therapy until receiving living donor transplantation using the right lobe in 2020. At the time of the transplantation, the patient showed moderate portal hypertension with low ascites and a low MELD score. The histopathological analysis showed a residual tumor of 4 centimeters. Here you can see on your screen the great tumoral response observed and the great liver atrophy, generally speaking, as a consequence of the multiple aggressive radioembolization interventions, among other therapies received by the patient. In this 7th and last case, a 57-year-old patient with a diagnosis of rectal cancer and synchronous liver metastasis showed for assessment. The primary tumor diagnosis was in 2011. The patient receives a resection of the primary tumor followed by multiple systemic therapy, resections and ablations, and the infusion pump placement. This is followed by external radiation and systemic ablation and maintenance therapy for the residual treatment of liver metastasis. The patient develops moderate portal hypertension with a low MELD score in 2020. The patient receives a liver transplantation with living donor using the right lobe, and the histopathological analysis, as presented on the screen, shows no residual tumor in the explanted liver, again correlated with the effectiveness of the pre-transplantation aggressive therapies that were received by the patient. This table summarizes the recently described cases of the 4 patients who are alive with no radiological evidence of tumor recurrence so far. 2 of them we have to particularly mention that are showing a prolonged transplantation procedure follow-up that is 2.5 years. And once again, none of those 4 patients I have radiological evidence of tumoral recurrence so far. We observed the penetration of the indication for transplantation due to unresectable liver metastasis in this new age. It has been progressing, and this is what we see when we search in the United Network sharing, UNOS, and we see that in the MELD era, we have been seeing 33 cases of transplantation in patients with metastatic liver disease that is non-resectable or due to liver injury as a consequence of prolonged treatments in patients with a recent history of liver metastasis due to colorectal cancer. 33 cases out of the 33 cases that were performed in the MELD era, 12 patients were before 2017 and 21 patients after 2017. As we can see, out of the 21 patients, 16 transplantations were done in patients with unresectable metastasis, and 5 patients received the transplantation because they had irreversible induced liver injury, chemo-induced liver injury. If we compare this to the cases before 2017, out of the 12 patients, most of them had transplantations due to chemotoxicity induced to the liver. We also can observe the survival curves comparing the cohorts before 2017 and after 2017 when we analyze the characteristics of the donors and the recipients. In the cases done after 2017, we see that almost half of them were done with living donors. When we think about the future selection criteria, we should consider some relevant indicators that are already used and others that should be incorporated because they are in evolution. To highlight them, I mean the monitoring of circulating tumor DNA, the genetic tumoral profile, and the mutation tumoral profile for which there are specific therapies. I'm referring to radiological and histopathological response to aggressive pre-transplantation therapies. And I mean the test of time from the resection of the primary tumor to the consideration of transplantation as a revealing element of the tumor biology. These and other elements should be incorporated into the selection criteria that were already proposed by the Oslo group, for instance, to create new, more advanced criteria for patient selection in order to improve survival outcomes in the post-transplantation time in the near future. I would now like to change the focus of the talk and discuss with you some concepts that are applied to the transarterial infusion pump, chemoinfusion pump, or HAI. Some years ago, there was a consensus meeting around the application criteria of this therapy, and some of the conclusions of that consensus include that this therapy should be implemented together with systemic therapy within the context of a multidisciplinary program including surgeons, there are hepatobiliary specialists, liver transplantation specialists, oncologists, interventional radiologists, nurses, and nuclear medicine personnel. This therapy should be considered in patients with metastatic colorectal cancer disease that has progressed to the first lines of systemic treatment, but is also acceptable as a first line of treatment in patients with non-resectable metastasis for the purpose of downstaging or as a target therapy. It's not advised to implement it in patients who also present extrahepatic metastatic disease because it was seen that there is no benefit in the survival for this group of patients. And regarding the application in the context of adjuvant therapy, it is possible to apply it in patients who are subject to metastatic resection, and then the implantation of the HAI pump in combination with the systemic therapy. Regarding the mechanisms through which we observe that this therapy can be effective, these include, first of all, the fact that the liver metastases are perfused mainly through the arteries, and also due to the fact that some drugs receive a high liver washout or extraction, like fluoxetine, which is the drug that was more frequently applied in the chemo infusion therapy through transarterial pump or HAI therapy, which makes the effectiveness of the treatment be high because of the high concentration of the drug in the liver, and also as a consequence of this, a systemic toxicity that is lower. As I already mentioned, establishing a program of HAI pumps is complex because it requires the availability of coordination of multiple subspecialties, including hepatobiliary surgeons, oncology, nuclear medicine, interventional radiology, and nursing staff. And this is one of the reasons why the implementation of this type of programs has not gone beyond a few centers in the US and some other countries in the world, so it's not generalized. This is the infusion pump that is most frequently used. This one is titanium, and it continuously elutes the chemotherapy. The pump is placed in a subcutaneous pocket, and its silicone catheter is inserted in the gastroduodenal artery. Before the surgery, a tomography, triphase tomography, is obtained with emphasis on the arterial phase to delineate the intraoperative hepatic artery anatomy. We inject methylene blue through the pump to rule out extrahepatic perfusion, and if it's observed, it's necessary to link the arterial branches that are accessory or aberrant. There is a post-operative check with technetium-99 to see if there is extrahepatic perfusion, and if it's the case, the aberrant artery branch should be embolized through interventional radiology. This is an example of local regional control reached in a 75-year-old male patient with advanced liver metastasis, as you can see in the tomography. The patient received systemic therapy followed by pump placement for infusion and multiple wedge resections. In the follow-up, as you can see in the tomography, a good local regional control was achieved of the hepatic metastasis as a combination of the systemic therapy and the local regional therapy with the HAI pump therapy. Among the reasons for which the transarterial infusion pump has not been implemented in a generalized way, we see the lack of prospective randomized studies. Once again, the complex coordination that is required among different subspecialties and the potential serious complications that can be observed related to the treatment, to this treatment, as for instance, biliary sclerosis and liver arterial thrombosis. Aligned with this, a retrospective multi-center study was recently published in North America regarding the feasibility and safety about the initiation of execution programs for HAI pump therapies. This included 6 high-complexity North American centers, 154 patients, and the period was 2003 to 2017, and the median follow-up of the patients was 19.5 months. When we analyze the immediate complications, we observed within the most severe ones around 7% of complications of the hepatic artery, and within the late complications, around 8% of biliary sclerosis. Regarding the tumoral response to treatment, we observe a tired tumoral response in 18% of patients, full, and 38% of patients partial, and a successful downstaging that is reached around 7.82% of patients. That is to say that the patients could receive a tumoral resection as a consequence of the downstaging that was reached with the HAI pump therapy. When we analyze the survival graphs, we observe an overall survival of 50% at 36 months, a relapse-free survival of around 10 to 15 months, and while this is aligned as you can imagine, with the advanced stage of the metastatic disease in these patients. So, concluding, regarding the application of the transplantation for colorectal cancer liver metastases that are non-resectable, we can say that post-transplantation survival in patients with non-resectable liver metastasis can be superior to the standard treatment with systemic therapy and similar to results observed in cases of conventional indications of liver transplantation. We can also say that the implementation of aggressive pre-transplantation therapies to induce total or near total tumoral necrosis seems to be an effective tool and one of great value to achieve better survival and during the selection process of patients. As we have seen, the treatment of relapses after transplantation is possible, and depending on the type of recurrence or the characteristics of the relapses, it is possible to reach an optimal survival. Aligned with this, I remember that as the case I presented, those patients who show very focal relapse, for instance, in the lung that can be resected, in those patients we have seen very good levels of survival being reached, quite the contrary to those patients who present multifocal relapse in multiple sites or non-resectable liver relapse would have a more ominous survival expectation. The selection criteria, including molecular predictors and the provision of new adjunctive therapies, will visibly translate into an improved survival in the near future. And of course, here the continuous shortage of organs is an element that is important to consider, and as a consequence of this, we should focus on the use of marginal organs such as DCD organs, splits organs, and living donor liver transplantations. Now, regarding the conclusions that we can draw regarding the chemoinfusion transarterial pump, or HAI pump, we can say that in spite of the lack of prospective multicentric studies, this is a tool that is simultaneously used with the systemic therapy and can be functional to the liver transplantation and also to those patients who initially present with a diagnosis of metastatic liver disease that is non-resectable. All of this then, in order to reduce the tumor volume in the liver, to maintain the metastatic disease limited to the liver, and to prevent the progression of metastasis in the liver. Having said this, we have to take into account the most severe potential complications that could be linked with this therapy, including, as we mentioned, hepatic arterial thrombosis and irreversible bile duct damage. Anyway, I want to repeat and emphasize the usefulness of this therapy as well as other therapies such as radioembolization at the time of effectively inducing a local-regional control of metastasis in the liver. With this, I would like to conclude my presentation and thank you sincerely for the invitation to participate in this fantastic meeting, and I sincerely hope that this talk I shared with you has been helpful. Thank you very much and see you soon.